Thank you for the invitation to take part in this important conference. International cooperation, I think, in the development of a patient-centered health system is absolutely needed. I come from the National Board of Health, as stated, so I work for the government, but not within the government. And it is certainly a challenge for the central health authorities to enhance the development from a traditionally acting health system where the patient is subjective for our sort of professional interventions into a health system where the patient is recognized as an individual with own preferences, competences, and wishes. It is also challenging to give a comprehensive description of a national perspective, as seen from the National Board of Health, on our national system, but I will try to do this. And the Danish National Board of Health is responsible for healthcare planning and supervision of the national health status and the health system. And I will try over the coming minutes to describe the national legislation and the national plan and strategies. The government has set a national strategy and goals for health of the Danish population. This strategy identifies the major obstacles to health and recognizes chronic conditions as a major challenge. It is estimated that more than 2/3 of the healthcare resources are allocated to patients with chronic conditions. So it has a huge political focus. The chronic conditions are the major causes for morbidity and mortality, and it is realized that involvement of patients and self-management support are very important issues. The core elements of the strategy are health promotion and disease prevention, as we also just heard in the discussion, that are important issues, but also self-management and rehabilitation. The national legislation on health give a strong impetus for stronger patient involvement. The Health Act gives very clear directions for the patient's right to involvement. All information concerning the individual patient must be shared with the patient if the patient wishes so. It is also the patient's right not to be informed. The patients have access to the medical record, and the staff has an obligation to interpret and explain the case records if patients so wishes. Equally important is the mandatory informed consent. No intervention or treatment can be initiated without the patient's informed consent, and this implies that the patient must be informed in order to give the consent. We use the chronic care model within our national strategy for health. And the Health Act gives the formal background for our national activities in improving patient involvement. The chronic care model has played a very important role as the framework for setting national action plans for improved care for chronic conditions. The central issue is that the patient should be informed and activated in order to cooperate and interact with the healthcare system. The prerequisite for this is support of the patient opportunities and possibilities for self-management. And this must be regarded as a major responsibility for the health system. And this responsibility is underlined in a recent international publication where the central elements in the chronic care model are described. The educated patient interacting with responsive healthcare teams. It documents a gap between expectations on one side and the actual performance of behaviors related to participation in healthcare and prevention. Significant clinical benefits have been seen from trials of self-management or lifestyle interventions across chronic conditions such as diabetes, cardiovascular diseases, and rheumatic arthritis. In order to mobilize these benefits, the health system must act in a way that proactively enables interactions and environments that promote health and well-being. And the healthcare system must recognize that health literacy and the patient's abilities to act should be supported. Patient involvement can be many. It can be a practical involvement in the care or monitoring of the disease, involvement in decisions concerning the treatment as defined in the Health Act about informed consent, but patient involvement can also imply organizational aspects. The national objective is to establish the framework for patient involvement on the individual as well as on the organizational level. The central players in this are healthcare as it is recognized in the specialized hospital settings, which in Denmark are organized at a regional level. We have 5 regions and we have a population of 5.4 million, small and flat. And the primary healthcare sector should embrace general practitioners and municipalities and also patient organizations. Patient involvement and self-management are central issues in the national strategy. The strategy or action plan is supported by substantial economic support from the national fiscal budget to regions and municipalities in order to develop disease management programs for the major chronic conditions, to support the implementation of such programs, and to stimulate patient involvement in the active monitoring and treatment of the disease. Maybe I should say that in Denmark we still have a very, very public healthcare system. It's just recently that private hospital, private care have become introduced, and it's still in its very, very early days. So it's mainly a public-based healthcare system. The Stanford Chronic Disease Management Program was piloted before we sort of implemented it, and it was tested for a Danish fit, and then it was implemented by the National Board of Health in cooperation with 2 regions, a patient organization, and the Danish Committee for Health Education, which you also were introduced to yesterday. This broad process, which involved important players in healthcare, was very successful, and the program has then been disseminated to the vast majority of Danish municipalities. In mapping out the disease-specific patient education, we found that there were numerous initiatives, but most of them were locally implemented. The objectives and the methods usually were not well defined, and the outcome definitely was not evaluated. So we initiated a development of disease-specific patient education. There is an increased evidence for the value of patient involvement in monitoring of symptoms or by objective measures as, for example, blood pressure, respiration capacity, or blood sugar. The possibilities are increasing due to the development of patient-managed technologies as glycometer, blood pressure equipment, or coagulometers. The disease management program for major chronic conditions are now being developed and implemented. The National Board of Health has set up a framework for the programs. The programs include guidelines for the specific treatment, medication or other treatment, the need for self-management support and patient education, and a description of the need and possibilities for active involvement of the patient in monitoring or treatment of the disease. The ultimate patient involvement is seen when patients are given opportunity and responsibility for monitoring and or self-treatment of their disease. We have recognized the potential and recommend self-treatment in the diseases and conditions where it is possible. Patients who manage their own treatment after education and instruction and who are offered sufficient support from their caregivers obtain better compliance and better quality of care. We have had a special focus on long-term anticoagulation therapy, as this kind of treatment is well documented and can be used as a model for other diseases such as diabetes, asthma, or maybe hypertension. The quality improvement is demonstrated in a number of publications. as seen here. A number of trials find identical results, that self-treatment results in a significant improvement of a parameter, and this is a proportion of time in a therapeutic level. And this, of course, leads to a reduction in complications, where the most serious and resource demanding is cerebral hemorrhage. A number of initiatives are now underway in order to disseminate and implement self-management in specific conditions. As described, long-term anticoagulation therapy is a focus area, and we expect vitamin K antagonists as being part of the therapeutic spectrum for some years, although new modalities are entering the scene. Self-monitoring in diabetes is well established, and the working group is now focusing on other conditions where stronger patient involvement is possible. The strategy for patient involvement, as I have described here, has a focus on those who are able to perform. But we must also focus on those patients who are unable to manage their conditions, at least at the upfront situation. Resources liberated by patient self-management must be reallocated to those who are weak, frail, or illiterate, and we must take responsibility for those patients. Studies indicate that illiterate patients benefit even more from patient education than those who are competent or knowing. So we must improve our approaches to that segment of patients, and we must keep our focus on social inequity in health, which even in highly developed European countries is a major problem. And we really recognize that as a problem in Denmark. This is just to illustrate the complexity and the many actors that sort of is centered around the citizen or the patient, depending on the health problem, and just illustrates that, of course, we will have to collaborate, we will have to communicate, and we will have to get our act together. But I think this illustration is definitely not an excuse for us not to involve the patients all the way. Thank you for your attention.